Lunch and Learn, welcome. And kind of the newest thing is the robotic surgery, and I could go over what that's all about. So really important is it's a robotic assisted surgery, so I'm not sitting there watching the robot do the surgery or anything like that. Okay? That's a pretty common question. But it's really to help with precision and accuracy in the surgery. We still use the same striker implants we used before, but now instead of using like cutting blocks and hand saws, we're using a robotic arm to help us guide the cuts. And then, more importantly, the software that we're using is helping us plan the surgery both preoperatively and intraoperatively, taking into account both the bone and the ligaments and tendons of the knee, which is unique to the robotics itself. So one thing is, this is not something that was just new to me. It's something I used in fellowship and got pretty excited about there. We did partial knee replacements and some hips in fellowship. And in March of 2017, Stryker launched the total knee application. Pretty much since then, I've been trying to get this here. Just a quick overview: arthritic knee, healthy knee. I think the X-ray is a little bit better way to explain that. The bone-on-bone arthritis. Most of you guys have seen those kind of things. So things to consider when you're having a joint replacement. I tell people, if you are you having less activity? Are you giving up activities of enjoyment? Is it harder to just get yourself dressed in the morning? Does the joint pain keep you up at night? Is a common question. And some people, if people can't sleep, then they have problems functioning during the day. Going up and down stairs is a common thing. We talked about just your activities of daily living. So when we're looking at partial versus total knee replacement, we're looking at what part of the knee is worn out. And there's a lot of ways we can be aggressive, but traditionally it's either going to be inside part of the knee or outside part of the knee, or if it involves two compartments, we're typically going to do a total knee replacement. All right. So if there's three compartments to the knee: the patellofemoral joint, the inside or medial part, and the outside or lateral part. So, approximately 700,000 total knees in 2017. It's supposed to double or triple by 2030. So we're looking at a couple million a year at that point. And what's astonishing about that is when we look at joint registries, 20% of total knee patients, that's 1 in 5, has some type of complaint or dissatisfaction. Doesn't mean it's done poorly or it's a bad total knee. They're just not happy with it. And so how do we get that down? All right, so we want to get that down to 0%. All right, but if we could just cut that in half, 1 in 10, or down to 5%, we'd have less patients who are unhappy with their knees. And when you think about 20% of 750,000, that's a lot of people. All right, so we use technology. There's a lot of different ways to do knee replacement as we go forward. Really, I shouldn't say there's a lot of different ways. There's a lot of different nuances to how you do it. It's all pretty much the same way. We're going to make an incision on the front of the knee. We're going to go in there. We're going to resect the bone that's arthritic. And again, I think one of the questions that I get a lot from patients is, are you going to take my whole knee out? Knee replacement isn't actually, to me, the best way to say it. It's actually a resurfacing procedure. We're going to take the ends of the bone off and replace it with a metal cap on the end of your thigh bone, and we're going to try and keep as many of your ligaments and tendons as we can. So the robotic arm is going to help us be more precise and more personalized for that patient. So each patient has a little bit different alignment of their knee that they might be used to, or they might have their ligaments might be tighter on one side, or maybe they're loose. And so the robotic arm and the software are going to help us plan for that and then execute that surgery with great precision. So this has been around for quite some time, with partial knee replacement since 2006, and with the hip came after that. And this is going to be a CAT scan. You guys have seen these before. Very similar to what you're used to with Dr. Miller getting a CAT scan for the knee replacement, all right? But instead of making an implant specifically for that patient, what we're going to do is we're going to make a surgical plan for that patient, and then during surgery we're going to tweak that plan even more. So once we get the CAT scan, we're going to get a 3D virtual model that's going to be loaded up into the software system. and that's going to help us plan the surgery initially. So that's where we're going to do kind of the classic standard cuts. We want to take off, no more bone than what we're really planning on putting back in for the metal, okay? We want to try and keep those standard alignment that we kind of are traditionally thinking about, and we want to size the implants up before surgery. So this is just a little picture of what we're going to get from the preoperative plan. So the green is where the new implant is. The dark gray is where we're going to make our cuts. And then you can see there, again, the resurfacing is really what it is, especially on the end of the femur. And it's not like we're just replacing your whole joint there, okay? We're replacing the whole surface of the bone. So we're going to get the fit that we like. We're going to make a plan that's kind of traditional for that patient. And then we're going to get into surgery, and we're going to we're going to expose the knee, and we're going to show the software or the robotic. It's got a little like a satellite, and we're going to show it where the bone is at. And so then it's going to marry in space where that CT scan is at, or where the bone is to the CT scan, and it's going to help us adjust any cuts that we want to make. So after we do that, then we're going to go ahead and take the ligaments, and we're going to take the knee through range of motion, and we're going to tension the ligaments, and we're going to find out where the patient is tight or loose. And so how this differs from a regular knee replacement is, typically you're going to make all your cuts first, and then you'll check and see how tight your ligaments are, and you'll loosen up your ligaments based on what your bone cuts are. Here we're going to go ahead and actually we're going to adjust what we do for that patient based on how tight or loose the ligaments are. So traditionally, what we're trying to do with a knee replacement is build a rectangle in flexion with the knee 90-degree flex. We want the same rectangle with the same amount of space in between the bones in flexion as we do in extension. And typically how we would do that traditionally is we'll make all our bone cuts, and then we'll make the ligaments fit the implants or the bone out, or the space is how we want. So we'll end up with a trapezoid, and we'll loosen it up so that we get a rectangle. All right? With this, what we can do is we can pick whether or not we want to adjust the implants, maybe the way it's rotated, and by using the CAT scan we can see if the patella is still going to track well based on what the patient's patella tracking was beforehand, where their trochlea is now, or that's the groove where the kneecap sits in. All right. So by looking at that, I can see on the CT scan, I can go through live action how that implant matches up to that patient's natural trochlear groove, and I can say, well, looking at the X-ray, they don't have any problems with patella tracking. So if I rotate that implant one way or another and I still match that groove, I'm okay to do that. And then we can also see that maybe someone who has a valgus knee or their knock knee, that sometimes they're actually deficient on their bone on the outside. So we don't want to take as much bone as we normally would. So we can rotate that implant a little bit one way or another. And what we're trying to do is trying to match those spaces up before we even make the cut, so that we can leave their soft tissue envelope alone, and that's where typically patients are going to have more pain. The more we have to strip the bone of the soft tissues, the more likely they're going to have issues afterwards. So then once we get that done, so now we've done a preoperative plan, we've shown the robot where it's at, and now we have we've made our intraoperative adjustments, and we have our final plan. So typically this is where traditionally we would put some cutting blocks on the end of the bone, and we would use a saw, just a hand saw, in order to make the cuts. And sometimes that bone's really hard, and it'll skive one way or another, all right? Meaning it'll dig into the bone, or it'll come up, and then that implant we've got to put on doesn't fit quite as well. So maybe now it's a little more flex than we had originally planned. Or it doesn't get all the way down to the bone. So what we'll do now is we'll bring that robotic arm in, and if it's a partial knee replacement, we use a burr to kind of burr the bone down so the implant fits right in there. Or for the total knee replacement, we'll use a saw. And you can see here, this picture is going to show me how much of that bone I've taken away, and it's good. And the robotic arm now is going to keep me from getting into the side areas. Okay, so if I get too close to this side, instead of having to put a whole bunch of retractors in there now, the saw will shut off. So it won't let me cut the MCL or the LCL, so that it's a protective mechanism as well. It's also going to keep me from getting in the back of the knee. It helps me get around the PCL without cutting the insertion of the PCL as well. The one thing it doesn't take into account is the soft tissue, so you have to pull the patella tendon and watch it very closely. But outside of that, it's a very good safety mechanism. The other thing it does, it tells you if you've taken all the bone. All right, so you have really hard bone and the knee wants to push away, it will tell you have to go back there and shave a little bit more off. All right. And then the other neat thing that it does is that actually once it's locked in, the robotic arm will move. If it's just a slow sway of the knee, if the knee moves just a little bit, so Ray loses steadiness a little bit, the arm will actually move with the knee so that it doesn't skive or cut or dig into the bone. And then if it moves too fast, it'll just shut off. So after surgery, then what we have here is a more precise surgery fit for that patient. So it's not a real long talk because the difference isn't so much the surgery itself, it's how we're able to be more precise and more accurate. And the biggest thing is being able to make that intraoperative plan. All right, so we're not just we're specializing the cuts and fitting the knee to that patient so that that patient maybe doesn't have to have as big of an MCL release. Maybe this is going to help us get rid of that medial pain that people come in, a year after they still kind of have some pain on the inside of their knee. They're better, but it's still not what they were hoping for. All right, and so that's really what we're trying to do. The other thing that it's really, I think, allowed me to do is become more confident with press fit implants. So, if we can get a more biologic fixation there, with now that we know that we don't have that kind of cuts or digs into the bone, we're going to get that 100% contact and get the good bone ingrowth on the implants as well. This is just some all right. So this is just a little bit of a timeline on what it was. June of 2006 is when the first makeover procedure was performed. About 83,000 hips have been done now. In general, the knee replacement is about 2 years old. March of 2017 is when it's launched. So it's not a brand new thing. And what we're doing isn't brand new. How we're doing it is just more precise. And then this is the common question. The arm is not doing it. So if you guys are familiar with any robotic surgery at all, the general surgery system is made so it's a laparoscopic surgery where the instruments are hooked to a machine with a bunch of arms, and actually that is where the surgeon doesn't have to scrub in. They actually use a 3D screen, and they'll actually perform the surgery almost like a video game in the corner of the room. This isn't like that, all right? So what it is it takes, the saw actually takes the place of the cutting blocks, and the software increases the precision and allows us to be more precise with the surgery. So early on, some of the results, and again, the guys who are doing this early have an interest, but the early results I think show some quicker recovery when you're looking at where they keep a little bit longer in the UK, and some less pain. But again, what I think is most important about this is whenever we're talking about implementing a new procedure, there's always a learning curve, and there's usually a risk to the patient with that learning curve. When they look at this procedure and adapting the robot, the learning curve comes in operative time and OR staff getting used to it. But when it comes to a risk to the patient, because you have that robotic-assisted arm that's shutting off, and what they're seeing is less bone damage and less soft tissue damage, even with people who are in their first couple cases. They're using less retractors. They're able to protect the soft tissues better. And so that to me is probably the neatest part about implementing this. So this is more of a patient talk part. Overall, I mean, the recovery is still expected to be the same as far as I'm going to tell patients 6 weeks till you can drive, 3 months to expect to get back to normal activities. Still going to take about a year to get used to your knee replacement. What we're hoping to see here is hopefully that earlier recovery, hopefully less stiffness. Now we know exactly what those gaps are, so we know that we're being more accurate. We're not making them too tight or too loose. So less stiffness, less instability, less of that patient coming back at 12 to 18 months, having a hard time going up and down stairs, a lot of tendonitis, bursitis from just too much laxity in the knee. So that's what we're trying to shoot for. So the goal is that they don't have shoulders out yet, but since we use Stryker, I'm hoping that we'll get to at least be kind of out on the ground floor of the shoulders. But no, shoulders aren't out yet, but that's the goal, is especially for the glenoid. And then hips, they have it. My only reservation with the hips is it takes pins on the opposite iliac crest, and sometimes those are painful, and some of the obese patients I worry about drainage. So I'm a little hesitant just because I think our hip results are pretty good right now to move forward with that. But certainly, I think the hip is one of the neatest things, because what it allows you to do is you plan preoperatively, and literally you put one reamer in there, so there's less of that in and out. It reams one time, and it's just such a perfect ream that it's a very good fit on your cup. So there's some advantages. Disadvantages, I'm not real excited about putting pins in the other hip. So some guys will say that it's time neutral, or as they get used to it. I've even had some surgeons tell me that they are faster with it. So as of right now, it takes us about 10 minutes longer, I would think, to do it. But in general, 10 minutes, it's not a bad thing. Now, if it was taking me an extra hour and a half, but as we get going, there's some fluctuation as we get used to. The biggest thing right now is trying to figure out how we want to handle things. We've done the same retractors for the last 3 years, and so we don't need all those retractors now. So it's trying to figure out. And then the other thing is the robot has to see where the leg is, and so where Ray stands is an important thing during the surgery. So just trying to figure out those little things, and once we get into a workflow, then the efficiency will come. Just Orville. Orville's the only place with robotics. So to me, the advantage is that we can be more precise, and knowing what the cuts are with the robot, and we can plan more for what their actual anatomy is, and not just fit them to the implants, but fit the implants to them. Yeah, that's the thing. I'm hoping that as we go forward, Stryker is currently working on a shoulder application and trying to be able to use that. So the difference is, so the custom knee replacement takes into account the bone, right? So there's no intraoperative precision as far as soft tissues as that goes. So this is the only thing that takes into account the soft tissues and the bone before you make any cuts at all. So when it comes to the custom knee replacement, it's the exact same thing as a custom or standard total joint replacement. Is you make all your cuts, and then you're going to release the tissues to kind of fit what you took out and put back in. So one of the things is when they do the custom knee replacement, they're projecting what that looks like, or what it used to look like before the wear and tear was on the bone, right? So if you have tibial erosion, so if that tibial erosion is on the medial collateral, and then there's some on the medial side of the tibia and on the distal femur, then they're projecting what that was going to be like. So you're going to have to release the tissues afterwards. And we'll do some releases. So sometimes we'll say, look, this is too much of a deformity. We can't correct it all by adjusting the implants. So then we know we have to do the release. But if we're adjusting the implants a couple of degrees, and we can see that the trochlea is lining up well, we're not taking an excessive amount of bone off, we're going to go ahead and do that instead of trying to do huge soft tissue releases, trying to decrease the amount of pain in the patient. The other thing is, if that patient's lived in varus for a long period of time, maybe that person's going to do a little bit better in 3 degrees of varus than if I correct them all the way. And so the theoretic benefit of press fit is that it's a biologic ingrowth. So the bone grows into the porous backside of the implant. So for a younger patient, what happens is cement is static. Once that cement is in there, it's in the pores, and as a patient becomes more osteoporotic down the road, those pores widen, and that bone, that's essentially what osteoporosis is those the pores in the bone become more, I say this, there's less interdigitation of the bones. There's less woven bone in there. And so now that bone isn't in between the cement as well. And the most common reason to have a revision is aseptic loosening. So maybe if we get the bone to go into the back of the implant, we're going to avoid some of that in the future. So there's that. And then there's some people that would argue that the heat from the cement, as it heats up, if you hold the cement in your hand while it's heating up, it's so hot, I mean, you have to kind of set it down. And so is the heat causing another level of pain? So that's one thing to consider. That's probably a little bit of a stretch, but in general that's there. Then there's also, to get into the back of the knee after you put the cement in there, can be difficult. Sometimes cement can be left in the knee or something like that. So we're kind of give you some advantages from that standpoint. And then varus is bow-legged. So if someone's bow-legged for a little while, then maybe that's how they're used to be, and maybe we don't have to correct them all the way back to straight. And they might feel more like that. The plan is 48 hours, so it goes down to Florida. Stryker makes it, sends it back to so in the operating room, I should say, there's two people with us. There's two what they're called Mako product specialists in the room every day. So one of them will bring the robot in and out, the other one will help run the software. And so it's not like the staff at the hospital has to figure out how to run this complex software. They're extensively trained on it. So that helps with the workflow a lot. So there's two extra people in the OR, but they help everything go smoothly from that standpoint.